order for the Los Angeles City Health Commission on Monday, September 12, 2016. The clerk could call the roll, please.
Andres Taylor.
Present.
Hisrich.
Here.
Hawkes.
Here.
Cotto.
Here.
Mandel.
Here.
Shannon.
Here.
Sharp.
Presente.
Vic.
Here.
8 members present and a quorum.
Great, thank you. Move on to approval of the minutes, please. Can I get a motion?
So moved.
Second? Someone has a second. So first and seconded to pass the minutes. All in favor, please say aye.
Aye.
All opposed? Okay. Is there anyone here to give neighborhood council comments?
No.
Okay, great. So we will move on to item number 1, which is our presentations on health-related issues. Dr. Jeffrey Gunzenhauser is here. He's the medical director of the Public Health County of Los Angeles to give us an update on the county response and outreach concerning Zika virus and meningitis. Thank you for joining us.
Thank you very much. Brought some handouts, so if I could,
You might
I
want
will.
to pull the mic a little closer.
Okay, I'll do that, sir. Here's a few extra for that side, and maybe if you wouldn't mind me. Good evening. Thank you. It's my pleasure to be here to speak with you this evening. I'm Jeff Gunzenhauser. I'm the interim health officer for Los Angeles County, and I work with the Department of Public Health. It's my privilege tonight to give you an update on two of our conditions that are high priority to us, Zika virus and invasive meningococcal disease. And I've got some, I'll walk through the slides that I provided to you, and then I'll open it up for your questions. Probably take me about 10 minutes to go through these. I also want to acknowledge the help of Dr. Benjamin Schwartz. He presented, I believe, to your commission earlier this year when we were first getting going around Zika virus, and he helped me put some of this together. So if you look at the second slide, these are the updates on Zika in the United States, California, and Los Angeles. And as I know you all know, this has affected the lives of many Americans. It's important to realize, even though in the United States there's been 3,000 cases diagnosed and reported, there are many thousands of other cases that aren't diagnosed because 80% of the cases are asymptomatic. And of those that do have symptoms, the majority of those are very mild, so they never get diagnosed. So these 3,000 cases diagnosed in the U.S. are primarily travelers who came back with appropriate symptoms or perhaps some serious types of side effects. So as you can see, the majority of the cases in the United States are travel associated. There are over 650 women who were pregnant also have had infections. And as you've heard in the news, there's been over 50 cases in Florida that are locally transmitted. They're working hard to contain the spread of the disease there among the local populations, but it's quite a challenge to control these mosquitoes. And of course, there's a number of sexually transmitted cases. California, as of last week, there were 260 cases. 2 of these were found to be sexually transmitted. There's been no local transmission in the state of California. In LA County, we've had 58 cases diagnosed as of last week. And in California, among the 35 pregnancy-related cases, 2 of those women had adverse birth defects at the time of birth. I think you'd heard about some of those. So that's the status of the cases in the U.S., California, and in Los Angeles County. If you go to slide 3, I do want to highlight, since Dr. Schwartz met with you, we've developed a very advanced mosquito, Borne virus disease prevention and control action plan. I would just mention that this focuses on all mosquito-borne diseases. We don't want to focus just on mosquitoes for one disease. As you probably know, we have 300 cases of West Nile last year with 24 deaths in the county. So we're continuing to try to focus on West Nile at the same time we focus on the threat of Zika. You can see the key elements of the plan are listed here, and we work with an awful lot of partners in implementing this plan. The next slide, I don't expect you to see it, but what I want to assure you is that we work very closely with the vector control districts. You probably know these mosquitoes, Aedes, is only present on the east side of the county and somewhat up in the San Gabriel Valley. So the map on the right there, any of the dots, the red or the blue dots, are places where we've actually identified Aedes or mosquitoes, and the triangles are actually cases. So whenever we diagnose a case somewhere in Los Angeles County, if it's in one of the areas where we have found these mosquitoes, we go to the vector control district and say, check out this individual in this area, see if any mosquitoes are present, because the mosquitoes don't fly very far, and if they do some mosquito abatement in those communities. So we're working very closely with the vector control districts in trying to track and, as needed, reduce the amount of mosquitoes in Los Angeles County. If you go to the next slide, which is a picture of photographs, this is one of the couple of the homes where where we found had a case trying to control the mosquitoes. This gives you some idea of the challenge, because Aedes can lay an egg in a very small amount of water, and the eggs are very resistant to desiccation over months and years. So unless people work very hard to eliminate this kind of thing, it'll be very difficult to eliminate Aedes mosquitoes from Los Angeles County. On the next slide, we just kind of highlight some of the resources that we've made available. We've reached out in multiple languages, lots of videos. We've reached out to many healthcare partners. We've issued a health alert, clinical guidelines, so we have all kinds of resources on our web to try to educate people. And of course, if people want us to make a presentation on this, we go out and do that. So we're doing all we can to inform people about the risks. And again, the greatest risk is right now for people traveling to locations where the virus is present. There are literally many tens of countries where it's present. Most of our cases come from Central America, sometimes the southern part of Mexico, but some LA residents have been in other places in the world. We've had no local transmission here, and we've had some sexual transmission in the state. We have some women who are pregnant in LA County who have infection, and we're tracking them because ultimately that's what we're trying to do, is prevent adverse outcomes in that group. I can pause for a moment to see if there are any particular questions about Zika before I move on to talk about invasive meningococcal disease.
Great. Commissioner Hisrich?
Oh, just so I can be clear, the Aedes mosquitoes have been around for quite a while, carrying various other illnesses, but this is a new virus. The Zika virus is something that has gotten into that population.
Yeah, that's correct. Aedes mosquitoes, there's two types we talk about. One is Aedes aegypti, which is the classic transmitter of yellow fever and dengue, and is a very good transmitter of Zika. That got introduced in the county only a few years ago. It wasn't here, but it has been here for a while. The other mosquito is Aedes albopictus. Again, it's not indigenous to California. It's called the Asian tiger mosquito, primarily in Southeast Asia, but it got introduced here recently as well. So it can transmit 4 diseases. It's yellow fever, which is a very serious disease. It's in certain parts of Africa, but it's not been imported into the U.S. There are occasionally cases of dengue fever, which can cause a severe hemorrhagic syndrome. There's another disease called chikungunya, which is present in the New World and also has been imported into Florida and Texas, and it causes severe pain syndrome. And then the 4th disease is Zika. So the mosquitoes are here, can transmit these diseases, rarely has transmitted the others, but has not yet transmitted Zika. Okay, well, thank you.
Yes, actually,
ma'am.
I have a question. This is Commissioner Shannon. I'm just wondering what kind of outreach is being done, particularly at airports, because it seems like the point of entry coming from states or other countries that have Zika virus is the airport. And I've been trying to get answers to what kind of education program is being done for people, maybe getting off the plane from Brazil or other places around the world.
Well, it's a good question. The question is, what are we protecting against? And it's hard to protect against a mosquito that could be imported. It's possible a mosquito could get on a plane from there. But the thing that most likely would introduce it would be a person. So let's say you travel to Nicaragua, you get bitten. You could get on a plane the next day and not develop any symptoms for 5 days, or up to a week, and then develop symptoms or not when you come back. very difficult to screen travelers for this. There are some educational materials at the airports. We've talked with them about this, but they don't have an active, if a flight comes in from Central America, reminding people about this and what to do. So it is somewhat of a challenge to reach out to educate all travelers from Los Angeles who come and go to there.
Yeah, I mean, I guess my main concern was human transmission, sexual transmission.
Yes.
And it seems like someone coming from an area that has a prevalence of Zika or a number of cases like Florida, are you even looking into maybe just having a flyer that you could hand out to people who are getting off the plane to remind them? Because it seems like, I'm not sure what the county cases were, but I'm guessing these are mostly people coming from other areas who then infected someone or impregnated a woman, and then that's sort of how we end up with this situation. Maybe they just didn't know.
I'll look into that more. I know we have worked with the airport in this, and they've talked with the airlines, but I'll follow up to see if more can be done.
Okay, great. Any other questions? Okay, great. So we'll move on to meningitis.
Slide 7 gives you a little bit of the timeline. I think you know that in late June, the time we recognized we had a third case of meningitis in Los Angeles County, we worked with the California Department of Public Health and some of our neighboring jurisdictions to announce these cases that were present here in Southern California. It was declared an outbreak. We put out a health advisory about using the vaccine. We requested assistance. I put in what's called a special request for an epidemic intelligence service officer who came here, helped us for about a month or so to make some recommendations. We got input from the CDC on the staff, in the state on those recommendations. Since then, we've been having weekly meetings with the state and with Long Beach Health Department as well as Orange County on making sure that we're all working together in our response to this. If you move to slide 8, just as a little background, there's been a general trend in a decreasing number of invasive meningococcal disease cases over time. You can see on here in the late 90s, we used to have about 50 to 70 cases each year, but more recently, in recent years, there's been less than 20 cases a year in Los Angeles County. Not shown on here, but in 2015, there was 12 cases, which is about the same as what we had in 2014. Just as a note, recommendations for adolescents to be vaccinated against this disease began in 2006, so there's been about 10 years where a large proportion of our growing population has been getting vaccinated, and that may be having some impact in recent years on the occurrence of this disease. The next slide, slide 9, summarizes all the cases that have occurred in Southern California, LA County. Since February of this year, there have been 30 cases of this disease reported in total from LA County, Long Beach, which is part of our county, and Orange County. Of those 32 cases, 26 are associated with this outbreak. And by that, we mean it's a certain type, and we have special tests that the CDC has assisted us with that confirm it's the same organism. You can see in Los Angeles County in 2016, there have been 15 total cases, but only 10 of those are associated with the outbreak. And among these 10, 8 have occurred among men who have sex with men. And of note, I'll show you on the timeline later, it's been about 6 weeks since we've had our last case here in Los Angeles County. Out of these 26 outbreak-associated cases, there have been 3 deaths. Those all occurred in Orange County. There have been no deaths among the cases this year in Los Angeles County. The next slide, slide 10, shows you a representation of all the cases that have occurred this year. The ones that are in the darker bars are the ones that are associated with the outbreak. The ones that are bright blue, the dark bar, are the Los Angeles County cases. And you can see if you look at that, the largest cluster of these cases occurred during the month of June. There were some in the month of July. The last case as part of this outbreak was back in the week of 7 August. That wasn't from Los Angeles County. The last case that's been diagnosed in this county was as of 17 July, so about 6 weeks ago. Now, with meningitis, unlike other diseases like with measles, where we would wait 2 incubation periods, which would be about 6 weeks, and if we didn't see it as any cases, we would declare it over. Meningococcal disease can have long periods, long gaps when you don't see cases and then later can come. And that's because the organism can continue to be transmitted among people without causing illness, and then later it could be picked up by somebody who then becomes ill. So officially, the Centers for Disease Control won't declare this outbreak over until a year has passed after the last case, during which time vaccine will continue to be offered free to anybody who would request it from us. On the next slide, we've talked about prevention and outbreak. We have an outreach. We've done an awful lot of work here to reach out to as many partners as are willing to work with us. It was our effort to convene the multi-county coalition so that Orange County, Long Beach, and us are working together. San Diego County has also adopted our vaccine recommendations. You may recall that in midsummer, we expanded the vaccine recommendations to go beyond men who have sex with men with certain risk factors to include all gay or bisexual men to receive this vaccine. And so all 3 of our health departments, that's public health, mental health, and Department of Health Services, provide vaccine to anybody who asks for it. We've reached out to large providers such as the LA LGBT Center, worked with the AIDS Healthcare Foundation, and others to provide them 317 vaccine and assistance as we can. We've done specific community events. We're reaching out to the other large providers like Kaiser, LA Care, and others to see how we can support them in expanding their vaccinations and outreach. And then in terms of communications, you can see the things we're doing here. We've done traditional media, but traditional media really doesn't reach this group very well. So we're trying to use social media and apps that this group might be using so that they're aware of the risks. They have some incentive to come in and get the vaccine, and hopefully they'll get vaccinated. So through the 317 vaccine program, which is a federally funded program that provides free vaccine, we've been able to provide thousands of free doses of vaccine in Los Angeles County. I will say that it is challenging both to measure how effective we are in terms of what proportion of the target population has actually been vaccinated. We estimate that the number of gay and bisexual men in Los Angeles County is between 250 to 300,000. Probably only a relatively small proportion of them have been vaccinated because it's not mandatory. So we're looking at ways of how we can estimate that better. There are some survey methodologies. For example, the National HIV Behavioral Surveillance Survey, which is done periodically, has a survey next June, and we're asking to modify that in ways where we can identify those who are at risk and ask whether they've been vaccinated, so we can get a better idea of what the actual rate of vaccination is in Los Angeles County. Well, the last slide here, like I said, we've reached out to a lot of partners, and a number of them are listed here, but there's a lot more that we're trying to do. This is a long-term effort. So even though we've vaccinated quite a few thousand individuals already, we really have got to get the numbers up. So we're doing a lot more outreach to other parts of the provider community, reaching out to representatives of the MSM community, find out what's the best way to communicate with them, and then to find best ways to bring them in to provide them vaccinations. So that's an overview on the status of meningococcal disease in the county. I'd be glad to take your questions. Yes, sir.
The new media outreach that you're doing, Grindr, et cetera, are they doing public service announcements for you, or do you have to pay for the time?
We do have to pay for it. We're trying to figure out how to build that into the application, and it's something we would pay for.
One would think that especially Grindr, they'd have a motivation to help the community, and that just like the airwaves and NBC, CBS, et cetera, that gives us a certain amount of public service announcements for free, that maybe Grindr, maybe politically, it would be wise for them to be nice to the community of Los Angeles and maybe donate some time instead of paying for it. Couldn't hurt them to have some good PR.
Thank you.
Any other questions? Commissioner Sharp?
Thank you, Dr. Gunzenhauser, for taking the time to join us this evening. I have a question that goes two ways, one towards the cities and then two towards the counties. Who's doing anything better, more effective, both in terms of the notification as well as the prevention, as well as the interdiction and vaccination, in terms of partnerships with local municipal governments throughout the county, in the context, obviously, of the fact we're a city commission and would love to know what the city of Los Angeles could do to be a stronger partner on this. And then going kind of more regionally, are there approaches being tested out in any of our surrounding counties that you're considering and or that we ought to be aware of to encourage you all to consider in the context of early notification as well as prevention and intervention?
I think generally the cities can be most helpful just to be aware, right? So people understand what is going on with the outbreak, and they understand that the vaccine is free. There's probably more we can do to provide cities so they have a full range of information. For example, the state did approve that for all adults, these vaccines would be covered free because it's part of the recommended ACIP vaccinations for adults in this group. So there might be some information that we can provide out to cities to be more helpful. But I think the two focuses are really how do we reach the affected population. So I know with West Hollywood, the city of West Hollywood, we're working with them to figure out how can we reach the population there more effectively. We know that down in Long Beach they're doing as well because really that has sort of been a focus of quite a few of the cases. So we're focusing there to reach out to faith-based group, other leaders in the community to say how do we reach this target population. And there's more to be learned there. I don't think we've figured it out completely yet. The question is what are the most effective messages and then what's the way that people can be reached best. So I think we're still in a learning strategy for that. I think with the other surrounding communities, I can get back with you on that, but I haven't heard that they have other practices that are really different than what we've been trying to do here in LA County. But all of our public information and communication offices are working together to develop those strategies.
Commissioner Andres Taylor?
I was just wondering what your outreach is to the physicians. And I say that because I heard the end of a segment on NPR, and they were interviewing men who had recently been to their physician, and 2 out of 3 of them said, well, gosh, if he had said something about getting the vaccination, I would have done it. So it seems like there's a little bit of a gap there.
There's a huge gap because what we recognize is that the conversation that needs to happen doesn't happen. So that if you need to identify somebody who's at risk, you need to ask them about their sexual orientation. And so oftentimes if somebody comes in, they might just say you're a male, so here's what's recommended, or you're a woman, so on and so forth. But they won't ask that question, because if they ask that question, then there's a number of health things that would follow from that, one of which would be meningococcal vaccination. So, what we've done, of course, is we have certain ways of getting information out. We have a health alert network that we operate from our county that directly mails information to providers, and we've put some out about this particular outbreak. But we realize that that's very insufficient, just because, like I said, there's probably a long list of things that a primary care doctor could or should do, but he or she just has to triage and decide what they'll ask, and they may not see this as a priority. So our goal is to reach out to the health plans and the hospitals to say, hey, look, can't you build in a reminder thing in your electronic system to ask every patient if they're in this risk category, and if they are, to quickly look and see. So, for example, I know the AIDS Healthcare Foundation has a really cool innovation that I talked with Whitney Engeron a couple of Fridays ago, and described to me that they had an event where people could sign up online to register to come get vaccine, and when they registered, it linked them with what they knew about their health care through AIDS Healthcare Foundation, and it figured out immediately who did and didn't need a booster. There are certain people that do. So through automated techniques, they knew that when they came in for their vaccine, who would get a booster dose, and they would send them an automated reminder. So the trick is we shouldn't rely on individuals having to think about this. We should take advantage of existing electronic health records to sort of program this in there. This will take some time, but I think those kinds of innovations that can be highlighted can show others how to do this better. The other challenge is when you have a disease like this that's fairly rare, as we ask people, they just don't perceive themselves at risk. Because the other side is if you know you need the vaccine, when you see your provider, we can say, look, go in and ask them. Say, I'm at risk and please give me that vaccine. And if for some reason they have a problem receiving it, they certainly can come with us. We know, for example, many of the small primary care providers can't even store vaccines because the volume that they would do is so small they can't refrigerate it and keep it for the rare patient. So we have to have ways that if they identify that person, refer them to us or another person who has those vaccines. So this is very challenging, and I think the solution is going to be innovation, such as the one I described from AHF, which is pretty good.
Question?
Commissioner Hisrich?
There's a certain amount of anti-vaccination hysteria that exists. Are there any things about this particular vaccination that people would find off-putting in terms of the way people react to it? Or is there a mythology around? Because if 5,000 have been given and the potential clientele is 250 or 300,000, we got a long way to go. I just want, I know nothing about, what's involved in getting it, but is there a aura around it?
No, there isn't. The first two vaccines in this class, Groups A and Group C, were developed by the military back in the 60s. W135 and Y came on in the 70s. I was in the service for quite a while. I oversaw the respiratory disease program. We administered hundreds of thousands of doses of this vaccine to all recruits every year. Some vaccines like typhoid and some others which can cause pain or swelling or redness, dejection site, are a little bit problematic. There were rumors, of course, about measles vaccine that are still out there but are totally non-true. But I've never heard of any suspicion about adverse events or anything from this. Of course, it's a killed type of extract. It's not a live bacteria or anything like that. But I will check into that. But I've heard no reports, and I've heard no rumors or myths of the kind that you mentioned.
There's no anti-vaccination.
That's right. There's a general anti-vaccination group out there, and I know some people just have a preference not to. But in general, everything I know about this vaccine is that it's very safe.
Okay, any other questions? I have a few. So do you track the private providers that provide the vaccines? Because I know you said you send out a health alert, but does any information actually come back to you from private healthcare providers or physicians?
We've looked at how we can track the vaccination rates. Of course, I think we have something called CAIR, C-A-I-R, which is the California Immunization Registry, which is a voluntary program primarily intended for children. So let's say you go to one pediatrician and you see another provider, they can quickly make sure they're up to date. We have encouraged its use for adult vaccinations as well, but it's very not very well known by adult providers, and it takes some effort to put it in there. But again, we're trying to work on automating it. So if you put it into your electronic health record, it could go right into CARE. Then we, as a local health department, could pull that data down. We've looked at it, and we think it's grossly unpopulated with the data that could be there. We try to work with the vaccine providers, the producers, to say how many have been shipped here. Very difficult. It's not the kind of information they would provide to us. And of course, we know what vaccine comes through the 317 or the VFC program, but that's about all that we know. So if we bring in 10,000 doses under 317 and we provide it, we can get good feedback from the groups that we've worked with. Now, we are trying to work more, but we're going to Kaiser, we're going to go to LA Care and the other large plans and say, hey, can you help us track in your population what your vaccination rates are? But that's still a minority of the population, so we've got a long way to go to reach out to other providers and organizations.
And is the goal to reach a herd immunity like with most vaccines? Yeah,
that would be ideal. Herd immunity varies upon what level is appropriate, depends upon how highly transmittable the disease is. For measles, for example, where an average case might infect 3 or 4 other people, you need to be well over 95%. Here, where it seems like it's a rare transmission, perhaps something lower in terms of protection level might really help to quell these outbreaks earlier. Very theoretical, that kind of discussion, but it would make some sense if we could get to 75 or 80%. I would say that has a high probability of limiting spread of this disease.
And when you investigate these social circles, how, like let's say someone is on Grindr,
Yes.
how then do you reach out to people they may have hooked up with sort of along the way to make sure that they're aware that they may have contracted meningitis?
This is a very difficult area. I can tell you that we're working very hard, for example, in the syphilis and gonorrhea outbreaks here in Los Angeles County at the same time, which has really taken off. And one of the drivers of that is that through these applications, there are hookups among individuals where we are unable to get useful information to track their contacts. So I would say that's less of an issue here, because generally the folks who are at risk are folks who are in their general contact, people that they would know. So they would be their friends or other close contacts. And so I think that in this situation, as opposed to gonorrhea or syphilis, we're likely to get the majority of contacts who would be the ones who would prophylax. So that is a key strategy. We've identified a case, and anybody who's had a certain amount of contact with them within the past few days, we would provide them a couple of days of antibiotics to clear them from the carriage. But the reality is if they've had the organism, they probably transmitted already to others. So it's not a very effective strategy at preventing this. It really depends on vaccination.
And I think since this is so prevalent among the LGBT population, is there a way that you could, and I don't know if you already have, but partner with like Pride or other sort of large festivals or places where people are gathering from that particular population in order to do a lot of outreach? 'Cause I think for this last outbreak, it was announced after Pride, which I mean was an unfortunate, that would have been a great outreach tool for you, I think, for the county to be alerting people at that point. So is there a way, or are you exploring any ways to sort of partner with other organizations? I know that you had a list of organizations that you were partnered with. I didn't see Pride on there.
Yeah.
Was it sort of like an outreach?
What we've done is we've scrubbed the longest list we can put together of organizations that serve the LGBT community. We came up with a list of over 100. And we broke them up into 3 groups. One is, are they medical and do they provide vaccines? Are they in any way a healthcare group? They don't provide vaccines, but maybe with a little bit of help they could. And then we have all the others that don't do any kind of healthcare delivery. So we're working with all of them. But I think you're right. Now that we've seen this twice in Los Angeles County, we've got to have an ongoing program of saying, how can we reach out to this community? Now, and we've looked at Pride events, I think, and just so you know, when the Centers for Disease Control looked at this, even though we know when the Pride event was, and we see the cases in June, they seem to think that the timing was such that it wasn't associated, but who knows? There could have been some transmission there for sure. But I think we've got to work together on a regular basis to say, what are the events where vaccination could be offered at the time, and how do we help with that? And we are doing that, particularly with the providers. So we have special events. We worked with Dr. Mills and some of the others here in LA County and set up a particular event to try to get hundreds of people. But yes, we are outreaching to them, and indefinitely in the future we'll try to schedule vaccination activities around their activities that work for them.
Great. Any other questions? Thank you so much for coming.
You're quite welcome. It's been my pleasure. Thank you.
Okay. Okay, our next speaker is Sonia Vasquez, Chief Program Officer for Community Health Clinics, giving us an overview of changes in medical insurance access and access to care. This will be post-ACA.
Something also disconnected by your foot.
That's okay. I just needed it to charge so that I can
I see. she ultimately got some of the vaccine?
No,
For the
whatever
recording.
makes you happy.
For the recording.
Yeah, we have
Yeah,
an
we could
HIV,
push.
Take this one.
or this one, the wings for HIV and AIDS.
Takes away
It's actually really
Dr.
good.
Mendel's
We have a
access,
mobile
but-
clinic, we go to the clubs, and we go out. Give it back. Yeah.
Which side do you want it on?
This is actually good right here.
Yeah, we have a
Okay.
dedicated clinic and stuff.
Can you hear me like this? Is this good? Yeah. Yeah, that way I can, that's fine. Thank you so much. All righty. So thank you all for having me. I really appreciate that. We're good? All right. So I have to say, I toyed with the title of this presentation, and I kept saying I should put a question mark at the end of post-health reform in Los Angeles, because we talk about that a lot, right? Post-health reform. And while there have been a lot of great things that have happened, which I'll talk about, there's still some challenges. We've all faced them, even those of us that have good jobs and have good health insurance, we see it. So just one correction, it's actually our organization is Community Health Councils. We are a policy advocacy organization located in South Los Angeles, but we have statewide presence as well. We focus on improving health systems and the built environment. And I can answer any questions about CHC afterwards. But I did want to share with you a little bit about, so what were the key healthcare changes that impacted LA County? And while most of this happened at the federal or state level, some of this has implications. A lot of it has implications for LA County, and some of it was not necessarily Affordable Care Act, ACA related, but are a result of just how things sort of have moved over the last couple of years. So in January 2014, as a result of the Affordable Care Act, we had the Covered California opened, which is our health marketplace in California, and our Medi-Cal program expanded, and I'll talk a little bit about how that happened. And then in October of 2014, LA County launched the My Health LA program. I'll talk about that. And then that's actually wrong. It should be May 2016. Clearly, I had aspirations for California to do things even sooner than it actually did. But May 2016 is actually California expanded Medi-Cal coverage to undocumented children, which was awesome. Okay. All right, so I don't know if you can see this, but these were the estimates, right? We said that, so for LA County, it was estimated that we'd have, on the good side, nearly 670,000 people to enroll in Covered California, and as a result of the Medi-Cal expansion, 460,000. We would still have over a million people that would remain uninsured, some of that because they wouldn't be eligible for anything, and some because there would still be confusion and people wouldn't understand what they were eligible for, or quite frankly, wouldn't want to purchase into the marketplace. So we would still have that. What we ended up with is, and some of these are not quite accurate, or we're not sure how accurate they are, just so you know, but so according to the LA County Health Survey, we have just over 2 million that are actually in adults, this is just the adult number, enrolled in Medi-Cal, which is an increase of over 1 million people. So some of these are people that came in because now they're newly eligible, and some because we just did such a good job of outreaching and engaging people that those people that would have been eligible before but didn't really understand the process came in as well. In Covered California, we have, as of March, the enrollment numbers are just over 375,000 in Covered California. Clearly, we are not where they expected us to be. A lot of that probably having to do with the premiums are a lot higher than people thought that they would be, even though we do fairly well in California. And then in My Health LA, as of July, we have 145,670 individuals in that, and we still have 750,000 who are uninsured, but that's a decrease of 900, almost 1 million people. So we did a lot better than we thought we would, according. Sure.
So if you look at your numbers, Medi-Cal increased by 1,002,000, and you decreased the number of uninsured by 981,000.
Yeah.
So my rudimentary math, that means it's 21,000. So basically all you did was take the uninsured population, place them into Medi-Cal, and another 21,000 people into Medi-Cal that, for whatever reason, weren't here in the county at the time.
Right.
So we haven't really population, the uninsured population just shift to becoming a Medi-Cal population. Is that not correct?
Yeah, well, I mean, yeah, so basically that's, right, because of the expansion, now you have more people that were now eligible for Medi-Cal as a result. So what happened, so I'll go back and I'll say, so this slide right here, this is what they assumed it would be. If you look back at the 2011, health survey, it was a bit more than what those estimates had as the uninsured rate. So yeah, I mean that's what happened. We basically moved all those people either because of the Medi-Cal expansion, or now you also had people that are now in My Health LA. Yes. Am I not answering that right? I'm sorry.
No, you answered it beautifully. I mean, the fact of the matter is,
Yeah.
what it really shows is that Covered California hasn't really had
Right.
a positive impact at all
Right.
in LA
It's
County.
Medi-Cal.
All it did was we shifted all the uninsured population in LA County onto Medi-Cal, and then we took some people out of the small group individual purchasers of healthcare and moved them to Covered California and subsidized them.
Right. Well, maybe. I don't know. I don't have those numbers to show how many people shifted over versus how many new people.
But-
Because I know in year one you had a lot of people that didn't have access to insurance, and so they jumped on. Especially those people that had pre-existing conditions and weren't able to get existing insurance.
But Dr. Mendel, isn't it true that the majority of those who have been enrolled in Medi-Cal to achieve this 1 million increase actually did so via Covered California? So Covered California exists as both a portal to different forms of private insurance as well as a portal to Medi-Cal.
Exactly. I think you're 100% correct. Basically, we use Covered California as being an electronic way of getting people into Medi-Cal.
Yeah, I will say, I always like to say Covered California was the shiny new toy, right? Everybody like to talk about Covered California, but the big impact of the Affordable Care Act is the Medi-Cal expansion. That's really where we see a lot of our numbers, especially in California. I mean, we went from, the statewide figures went from about 7 million to, I think they're now close to 14 million people in Medi-Cal. So it's a lot, and a large number of them are in LA County. Okay, so just quickly, I just wanted to make sure, I don't know, I'm assuming you all know about the expansion and all the coverage programs, but I just wanted to make sure we were all on the same page. Medi-Cal now provides free, low-cost health coverage in California. It used to be that adults had to have a linkage, so you either had to have a child, blind, disabled, over 65 to qualify. That's no longer the case, so that opened the door to a lot of adults. Former foster youth are eligible to the age of 26, must be a California resident, U.S. citizen, a national, or lawfully present, must be income eligible. Documentation changed, so you can do more electronic verification. That we didn't have great success with in the beginning, but it's getting better. And no more asset tests for most people. Some people still have to do an asset test. Covered California is the place where you compare, apply, purchase coverage. It's the only place you can get the subsidy. You cannot get the subsidy outside of Covered California. And it's for everybody that's above income level for with a caveat. So mainly above income level for Medi-Cal, which again, for Medi-Cal for adults, it's 138%. For children, it's 266% federal poverty level. The caveat is there are some immigrant groups who have citizenship but are not eligible for Medi-Cal. They are not considered qualified immigrants. So their documentation status says that they can only purchase through Covered California. So you can actually be under 138% and purchase Covered California for certain immigration statuses. Hope that makes sense. Okay.
People within 5 years of getting their
Technically, in other states, California, at the moment, we pay out of our pocket. So state funding goes to provide Medi-Cal for those who are under the 5-year bar. But federally, yes, they would have to go into the exchange. But there are other designations, and there's like a whole laundry list. If you want them, I can send them to you. That do not allow you to be eligible for Medi-Cal, but you can be eligible for a subsidy.
And if you get a subsidy, you're under the 5-year rule, is that paid by the state of California 100%, or is it matched with the feds?
So for California, for Medi-Cal, for those under the 5-year bar, that's state funding. It's not federal funding.
But what about, do they get subsidized on the exchange?
They do get subsidized on the exchange.
Is that true countrywide or federally?
That's
or does-
statewide.
doesn't-
That's nationally. Yeah. And then My Health LA is the county program. We used to have a program called Healthy Way LA, which was for those who were undocumented. Once the Medi-Cal expansion occurred and we moved everybody who was eligible into Medi-Cal, LA County created what they call My Health LA. It is not considered a coverage program. It is an insurance program because there are limitations. Unlike a coverage program, for the most part, you can go anywhere. With this program, your primary and preventative health care is all done at contracted community clinics. Specialty, emergency, and urgent care happen at the Department of Health Services, as well as drug and alcohol treatment services, and some dental in some clinics. And then in May 1st, 2016, all children under the age of 19, regardless of status, who are income eligible under 266% federal poverty level, can now enroll in Medi-Cal. Those who were enrolled in restricted Medi-Cal were automatically transitioned. And I apologize, I don't have the numbers for LA County, but I will try to find those if anybody is interested in that. Okay? And did you have a question? No? Okay. And then there were other things that happened too. Some things as a result of the Affordable Care Act, and then just the other things that started to happen federally and here in California. There was a lot of funding for bricks and mortar, so we see the number of school-based health centers increase because clinics were able to get that money and put it into school-based health centers. A lot of clinics upgraded their sites, so you see them looking better. MLK was rebuilt not solely on funding from the Affordable Care Act, but it did have some funding from that. Clinics began to start improving their processes. This has been a bit of a challenge for a lot of clinics, but they're moving forward on electronic health records, becoming patient-centered medical homes, and really working on integrated systems of care, connecting clinics to the hospitals and specialty care. LA County is going to be serving more Medi-Cal beneficiaries through California's Medi-Cal 2020-11-15 waiver demonstration project. They submitted their whole person care pilot, which will help them serve a number of populations, primarily homeless, those with chronic illnesses, and those coming out of the jail system, the county jail system. And they're expanding their substance abuse use disorder system, which will allow them to provide a more comprehensive set of services. They say, the way they phrase it, it's the right care at the right time for you, basically. So and if you haven't had anybody come talk about that, that's a really exciting new program that's going to be happening that you should have come out. However, challenges still exist. We still have a lot of people that do not have a usual source of care. Even when they have coverage, the managed care system can be very confusing for people, so they didn't understand they were supposed to pick a provider, they were defaulted, they don't understand where they were defaulted or how to get that, so they consider that they don't have a usual source of care. Obtaining medical care can still be difficult, primarily because the demand is increasing faster than the supply. We have a huge healthcare workforce shortage across the nation, but in LA County and in places like South LA are even worse. Our reimbursement rates are not increasing to what they need to be. There continue to be technology issues. A lot of clinics don't have the same electronic health records, so going from one place to another can be confusing, and people don't have their same systems. The system generally doesn't always meet everyone's needs, and it's completely, and it's not always, and it doesn't always completely meet that should be the myriad of social and economic factors that patients face. Clinics are working really hard to be a place where they can help people with with all of their social determinants of health, but that's really hard for clinics because they have a lot of requirements that they have to meet, and sometimes the way that we bill for services, you can't always pay for everything that needs to happen, especially on the preventative side of things. And that's it. So any questions? Yes.
Commissioner Hischer.
Sure. Well, in that last category, the ones that don't have a usual source of care, any estimate of how many people there are in that category, and then how many people aren't covered at all? In other words, not that they don't have a usual source of care. Are there still people that meet no eligibility requirements for any of what you have described?
Oh, yeah. So I do have the numbers for the usual source of care. I hesitated putting it up there just because I still had some questions about, this is from the last LA County survey. They estimate that there's about 1.5 million in LA County that still don't have a usual source of care, but that's not broken down by program, so it's hard to say how much of that is because they're still uninsured or in a program. And then in terms of not being able to access medical, or who reported having trouble accessing medical care, there's about 2.2 million in LA County.
And that they have trouble because they have no coverage, or they don't know how to use the system?
See, that's the question, right? I don't know, and so I hesitated putting that up there because I didn't know the answer to some of that.
That's a pretty big number.
Right, so it's probably a combination. You know, some people that are just having trouble because they don't know how to get into the system. It could be, and I think they have one for specialty care, which I need to look up, because there's a difference too, because you can have a primary care doctor and everything's great, and then you have multiple chronic. I have a friend who's in Medi-Cal and has literally, every time he goes to his primary care provider, because of the way it's set up, he has to get referred for every major issue, and he's literally gone, in the last 4 months, has gone to see 6 doctors. And, you know, dealing with transportation and those kinds of things. So it's a myriad of reasons and why they have barriers.
Any other questions? Okay.
You can go first.
Commissioner Sharp.
Oh, no, please.
No, that's okay. Go ahead. I'll go last.
Thank you, Sonia. Appreciate you taking the time to come here with us this evening and enlighten us on a fundamental subject to the health of Los Angeles residents. I serve on another city commission that oversees the community investment side at HCID LA, and I've heard extensively about the efforts the city has been part of over the last 3 to 4 or 5 years to use the Family Source Center system and the libraries and every possible portal, including even paramedics, to increase awareness of both My Health LA as well as the options through Covered California. And I guess I seem to have no ability to identify gaps in that, given that the numbers show a pretty substantial spike. My question is really on the other side of the equation. Are there things that other cities are doing throughout the region or the county that the city of Los Angeles ought to be looking at to help strengthen the actual provision of care? As you described in the last part of your remarks, there's that transition from opening the door to the eligibility for medical insurance at a subsidized rate. Which has its complications. I personally am insured through Covered California, self-employed person, so I understand the complexity of that doorway, but it seems to me for the health status of residents, all those gaps on the actual provision of care end are substantial to for us to consider and to see if there's a way that the city of Los Angeles, to whom we're accountable, can be helpful. Are other cities doing better? That's my question.
Yeah, I would have to look at the data to give you, I can't answer that question specifically, how other cities are doing or how they're doing it. I think that what I know to be some best practices in other cities is really thinking about how and where you provide care. I think that the majority of our problems with the system really lie in the Medi-Cal program. It's just the way it is provided is really complicated. I was fortunate to go to Cuba a couple years ago, and now they have a whole host of other issues. Yeah, but at the end of the day, you had your one doctor, your nurse, and your team, and everybody worked together to provide care for you, and it was really nice. And so I just think we overcomplicate the system just generally, and I don't know that LA County or LA City can really fix that. Like that's a national issue. But I think, things are changing in terms of clinics really trying to figure out how to do this better and working together better. What's hard, and I really wanted to give you city data, but it was hard to get, quite frankly, because most of the system is countywide, right? It happens at the county level. There's very little that can happen at the city level, other than figuring out how to really make sure that people understand how to utilize their coverage and the importance of preventative care, and being aware of of when it's not working the way it's supposed to work, right? So making sure that our residents really understand when it's not working and who to go to for support when they need help.
So I guess my curiosity is really based on the fact there's this enormous pipeline that's been built, right? The city of Los Angeles has a substantial infrastructure to support medical insurance enrollment, even though it's primarily a state and county responsibility. And I'm just curious if there's thinking maybe to take back, and we can correspond subsequently, regarding whether this pipeline, which involves the libraries and family service centers and a lot of infrastructure, can be modified, or other communiques can be put through the pipeline to strengthen the use of care, the use of the benefit.
Yeah.
Because there's actually a lot of people throughout the city who now know about Covered California.
Yeah, I mean, I think so. I mean, I think you can use the system to better explain to people how to use their care better. And again, it's not, you can see it's not just Covered California. It's really the Medi-Cal and other programs that we need to explain to people. And quite frankly, I mean, other than some of the sort of glitches, sort of, getting in the system and dealing with your health plan, once you have coverage through Covered California, it runs, I mean, and if you're familiar with private insurance, that runs pretty smoothly. It's the Medi-Cal system that can be very complicated for people, and that's the one we really have to explain, because what ends up happening is people say, well, forget it, I'm just not going to go. Or I'm just not going to go deal with my high blood pressure or and so people need to understand that even though the system doesn't work right the way we want it to work, that this is the system we have, and we have to get them going to care so we can improve their health outcomes. Because quite frankly, it doesn't matter that we have all those people enrolled if we're not getting them to care and making sure that their health outcomes are improving.
Commissioner Mandel?
Oh, okay.
Question and then a response to Commissioner Sharp. So the question is the federally qualified health centers. We have a very significant number, actual individual clinics. Last time I checked, was something like 285 of them, and I think there was like 77 individual federally qualified health centers. Do you have up-to-date numbers of how many patients are being seen in that system? And if so, has that been changed from the ACA and expansion? And then I'll make my comment after you answer.
I don't have the exact numbers, but I can get those for you. Those are available. And just anecdotally, I can tell you it's been a huge expansion for them, right? Their numbers have gone up a lot, and therefore the types of patients they're seeing has gone up a lot, right? So more people, now that people have access to coverage, they're seeing more people that have chronic illnesses. Now that not that they weren't seeing homeless patients before, but now that they can really treat them and see them, now the issues that they're dealing with are a lot more pervasive. And quite frankly, that's a population where the Medi-Cal managed care system doesn't quite work for them, because they don't have home addresses and ways, transportation to get to when they need to see specialty care. So the types of issues they're seeing has increased, and so it's created a backlog's not the right word, but more issues for them to have to deal with when they're trying to figure out how to serve people better. They are not, and then there's a whole slew of private doctors, private practices that are now seeing people that also do things differently, right? I think in a clinic setting, they're set up to kind of deal with the social determinants of health a little bit better. Private doctors, not so much. And so that's been an area that we've been interested in looking at and really seeing how are private doctors, private practices really sort of supporting these clients, these patients with other services that they need, preventative type of services, nutrition, resources, all of that kind of stuff that we know that happens in clinics, but is also not really funded, right? And so I don't know how many private doctors are able to do that. So that's an area that we're really interested in looking at as well.
The response to that last part is, I think that's when they use the term private doctors, that's really a misnomer, because most of those private doctors have sold to one entity or another entity. So their private offices are now owned by some larger
Right,
group.
That's true. That's true.
So which is a little different than what we all envision as a
Right.
private doctor.
You're right.
And it would be important, because if they're a big system, then it would not be that difficult to do the health education and other things, because the system can just do it electronically.
True.
And just force it into all the little clinics. If they were motivated to do that.
Right.
They will be at some point in time, but not now. And then in response to Commissioner Sharp and why the problem. The problem is that we've expanded Medi-Cal in the state of California much more than most other states. So now 35% of the people in the state of California have Medi-Cal, where nationwide it's more like 13%. So we've expanded more than most of the other states. The other thing is we pay less. And so we're number 48 in comparison as a percentage of Medicare payments, which is somewhat regional, but not exactly. And so if you look in California, at least, if you're 48th in payment, you're not going to have a lot of doctors where it costs more money to practice for a lot of different reasons, some of which is tort insurance and rent, et cetera. If you look at the rural parts of our state, they're actually pretty high acceptance, and we're not having as much of a problem with Medi-Cal. But if you're looking at inner cities, South Central, for example, or the larger areas of density within in the state, that's areas where you cannot find a Medi-Cal specialist for the most part. They just don't exist because they can't afford to really practice. And that's a big problem. So I'll give you an example because I know the OB reimbursement rates. So 10 months worth of care, Medi-Cal pays an obstetrician for 10 months worth of work, about $880. Okay, in Alabama, okay, the same care gets paid $2,600. The last time I checked, the rents in Alabama are a little bit less than they are in the west side of Los Angeles, Long Beach, or downtown LA. And so there is a big reason why it's hard unless you're going to one of these big clinics, which is more of a, and OB is a special thing because it's really primary care in some ways. But if you're looking at things like neurosurgery, orthopedic surgery, dermatology, psychiatry, you just can't find a Medi-Cal doctor who's going to do it unless they're affiliated with a big system. And one of the big problems in LA City, at least, or LA County, but definitely LA City, is that when you look through the Medi-Cal approved physicians, most of them are teaching centers, and it really isn't those doctors. So what happens is you'll have 19 professors who are spending approximately 85% of their time teaching or in research laboratories, but their name's on the list, so it looks like there's a lot of people who are on the thing. But in actuality, it's the same small number of residents who are running around on roller skates trying to see all those patients.
Right. It's very complicated. I mean, I think, another area that we're really looking at is our primary care pipeline, and not just primary care physicians, but specialty care as well, and trying to see what kinds of policy changes can we make, because we know universities are also having problems with trying to, get people in and having the right professors and having teaching hospitals or residency slots that maybe aren't in hospitals but are also in clinics to kind of help. But that's another a challenge for a lot of clinics, because that's another thing that they would have to do, although they want to do it. I always say that as much as I love the Affordable Care Act and I think we did a good job, I feel like we did things backwards. Like, I think we should have worked on fixing, if we wanted true health reform, we needed to work on fixing the system before we brought all these people in, or at the same time, but it is what it is.
Do you track, this is Commissioner Shannon, do you track other barriers such as the length of time it takes to get an appointment with a doctor, transportation issues, access to medication, pharmaceuticals? Because I'm just wondering, I work primarily with people who are homeless, and they have additional, if they're living on the street, they have additional barriers, which that they have to leave their stuff in order to go on a doctor's appointment, and that creates its own barrier. But I'm just wondering if you track this at all in terms of, because I remember it used to be, before the Affordable Care Act, and a lot of people were not at Medi-Cal, they would utilize a lot of the free clinics, but they would show up, very early in the morning, really at night, to be seen, and the doctors would come out and pick like the first 4 or 5 people, and then everyone else had to go home, and they weren't seen. So I'm wondering, has that changed now that more people are in the system, or are we still sort of facing that same thing where it's the length of time to see a doctor, number of people lined up are still, very few can be seen?
Yeah, I don't have the exact numbers, but I do know a lot of those barriers continue to exist, right? You still have people, because it still can take a while for you to set up a doctor's appointment. And so some people know when they can go, like if they need to see somebody right then and there, when they can go. So those problems still exist. It's interesting, we just did, not a focus group, but we did some key informant interviews with some of our clinic partners to ask about the issues around homeless population. And medication came up as one of the number one things, because a lot of medication has to be kept at a certain temperature. And if you're moving around, you can't you refrigerate your insulin or whatnot, right? Or have it in a place where you can make sure that you can access it. So there's a lot of, things continue to be a huge barrier, and for certain populations like the homeless population, it's even worse.
Any other questions?
I wanted to comment to Commissioner Hawkins on Commissioner Mendel's issue about FQHCs. So I work for Ultimate, the largest FQHC in the country, and actually the whole ACA has done an amazing things for us. We're able to expand, and now FQHCs we have to basically see everyone. So now there's a funding mechanism and stream, so we're able to expand and provide services that we weren't able to in the past. So Ultimate actually was the #1 ACA enroller for the past 3 years. So we've done really, like I said, we've done really well. It's worked out for us. So now we're trying to look at the impacts now that the ACA is winding down. So so it's really interesting to see how that transition is going to, how it's going to work out. But ultimately, it's been a good thing for the FQs.
And what percentage of that was Medi-Cal versus exchange, non-Medi-Cal exchange?
Oh, actually, I'm not sure. I don't have that on me right now.
Well, that'd be the model. I mean, the federal qualified health centers or the free clinics, which now in LA there are virtually none because of other reasons. But those would be the clinics you'd want to expand.
Right.
Because they already have the infrastructure. All they need is the funding.
Right.
So if you block granted all the FQHCs as well as the handful of community clinics that exist that are not or lookalikes, and or the one free clinic that still exists in LA County, when we used to be the originator of the concept nationwide, if you expanded them, and you could easily do that because it just takes money to hire nurse practitioners and or physicians and some infrastructure costs.
Right.
You have to expand their EMRs as well as some bricks and mortar. You can expand it and rapidly turn those clinics into systems that work better.
Yeah.
Additionally, if you look at the hours that they're open, if you have the bricks and mortar, you can really expand that easily and have weekend hours or evening hours or start early in the morning hours much easier than you could ever do in any other clinic because they have staff and they have shifts. So it could really be done if anybody really wanted to do it. It's just going to take money, and there's nothing in the ACA for that.
Right. I think that's the issue, and I would say Ultimate's probably on the better end of your success. But I think the challenge is staffing and money. For a lot of the FQHCs, even though they've had a lot of improvements and things have gotten better, and now they have a reimbursement mechanism, the reimbursement still doesn't pay for everything, right? And I know that, and the state is working on it. They're doing a reimbursement pilot that will look at it differently, versus more of a. I'm not going to talk about it because I can't explain it right. But I know they're looking at changing some of that. So things are changing and they're getting better, but the challenges still exist. And I think it's an opportunity for all of us to try to figure out how we can do this better.
Thank you.
Thank you.
Is that it?
Okay. Any other questions? Thank you so much for coming. Okay, so we'll move on to public comment now. Mr. Spindler. I'm sorry, I forgot a presentation. I'm sorry, we're not ready for public comment. I'm sorry, I have one more presentation by Yolanda Chavez with the Office of the City Administrative Officer for the City of Los Angeles on comprehensive homeless strategy.
Would you like me to sit here? So good evening. I'm Yolanda Chavez, Assistant Administrative Officer. Great to be here with you to give you an update on the comprehensive homeless strategy. What I thought I would do is just give you an update to where we are, and then I'm sure you'll have questions. But as you know, the city approved a comprehensive homeless strategy in February of this year. It has 64 strategies, and this is what the strategy looks like. And I'm sorry I couldn't bring copies for you all, but unfortunately there was a limited number printed, and you could see this one has my name on it because this is what I use for my work day in, day out, as we're tracking these strategies. So what we started doing immediately was figuring out a way to implement the strategies, of course, as soon as the plan was approved. And then when the budget was approved, you probably heard that the city actually increased their funding of homeless services by really almost 150%. So this year, for the first time, the funding for homeless services was above 100 million, 138 million. The prior year was something like 20 million. So we were very excited about the commitment the city has made. And I want to say that I actually came into this role in April after being at HUD, the U.S. Department of Housing and Urban Development, in Washington, D.C., and the U.S. Agency for International Development. And prior to going to D.C., I actually worked for the city housing department, the prior LHD, now it's called HCID. But I can tell you that coming back, what's really exciting, even though we have this tremendous problem of 48,000 people who are homeless in the county, about 28,000 of those in the city of Los Angeles, is really the unprecedented collaboration between the city and the county, between all agencies within the city and the county, and of course there's incredible support from private partners, in particular the United Way, who actually leads the Funders Collaborative. So they've been extremely supportive in terms of our efforts. So in terms of the strategies, they are all progressing very nicely. There's about 24 of them that have been prioritized by the City Council. Another 9 were funded. So we're really focusing this year on 33, but all 64 of them are being tracked on a web-based system so that actually all the lead departments report monthly as to where they are in each strategy. And our first quarterly report will be due in October, and then we hope to report to the City Council in terms of the first quarterly report in late October. The other thing you should know is that part of the tracking of the strategies and where we are is that there's a homeless strategy committee that was established as part of these strategies that meets monthly. And that committee is made up of the CAO, Mayor's Office, and the City Legislative Officer, or the CLA. And so that, again, this committee meets monthly where departments come to report on the status of their strategies. And I think you probably also know that the City Council actually established the first standing committee, homelessness and poverty, really anywhere in the country. And so they meet twice a month. And again, we report on all of these initiatives before that committee as well. So in terms of accountability, we're really ensuring that these strategies are moving. The CAO and the CLA have been charged with ensuring that the strategies are implemented. And a part of this is hiring a city homeless coordinator, which you may have heard because the press release was issued last Friday, I believe. But our homeless coordinator will start October 3rd. She will be housed in our office at the CAO, and her name is Meg Barkley. I am extremely excited. She actually worked with me at HUD, and so I'm very excited that we're going to be working together again. And so, because this is homelessness and housing is part of my portfolio, so I will continue to work on this issue. I think in terms of what's of interest to you in terms of health and how we're coordinating, especially with the County Department of Health and the County Department of Mental Health, is one, I think you're also aware that the City Council approved a ballot measure that will be on the November 8th ballot that, if approved, then that's measure, I think, HHH, will allow the city to issue $1.2 billion in bonds to develop permanent supportive housing, and affordable housing, and facilities as well. So we're very hopeful is that when the measure passes, we'll be ready to implement a program, and we actually started to develop the program in terms of the housing portion of this. One of the things that we're doing in preparation for that, and also even if it doesn't, just to ensure that we're able to expedite the development of supportive housing, is we're in the process of developing a MOU, or Memorandum of Understanding, among the city, which would be HCID, the county Department of Health, and the Housing Authority of the City of Los Angeles, or HACLA, that will basically ensure that when developers get funding from the city to build supportive housing units, that basically the three sources that you need for supportive housing are committed to at the same time. So the city, of course, provides the financing for the supportive housing units. The Department of Health provides the services that are needed to go in combination, to make it supportive housing, because I think, as you all know, supportive housing is a combination of housing with services, including mental health services, job training, et cetera. And of course, the Housing HACLA will provide the project-based vouchers, which actually make the units affordable, right, and provide the operating expenses that make the project affordable. So you really need all three sources of financing to be able to build supportive housing. So that's one of the things that we're doing with the county and HACLA. We're working very closely on this MOU. The other thing that I think you're aware of is the city, in terms of the funding that we provide for homeless services, we actually do that through LAHSA, or the Los Angeles Homeless Services Authority, which is a joint city-county agency. And so they also serve as a coordinator between the city and the county. And some of the funding that we're providing this year actually allows LAHSA to work with HACLA and provide incentives to landlords, because, as you know, part of the challenge is the lack of housing inventory within the city of Los Angeles. So this landlord incentive really allows landlords to hold the units so that homeless individuals can then rent the units while HACLA is going through their inspection. And then HACLA connects with the county so that if that residents need services, the county is able to provide case management to that resident. And so LAHSA is a really key partner in terms of our coordination with the county. I think the other thing that's important to note is that in terms of the flexible housing program that's provided by the county, the majority of those, I guess I would say, rental assistance and services are actually being provided to residents within the city of Los Angeles. So in essence, the plan is, again, moving forward. We spend a lot of time every day ensuring that these strategies are moving forward, working with our private partners, meeting with the county. You should know that we meet with the county and our private partners on a monthly basis. And then we have separate meetings in terms of coordination with the county, because a number of the strategies in the city plan and the county plan are identical. And so part of that is coordinating to ensure that if it's a first responders training, that LAPD and the sheriffs are coordinating on that, that if it's the same strategy, that we're going to be collecting the same data as we start to report and analyze impact of these strategies. So I'll close there and answer any questions that you may have.
Okay, any questions? Okay. Commissioner Sharp.
Go first.
No, I have a ton, trust me. Go ahead.
Do a couple.
Okay, so I work with the homeless population here in Los Angeles. I tend to mainly work on a council level with a lot of council members. So I have a few questions. So one of the things, and I think we've actually passed a resolution here supporting the Housing for Health program with the County of Los Angeles. And one of the things that they do, which I think is extremely important, is that they have this flexible subsidized housing pool, which allows them to be outside. And I know that you come from HUD, but it allows them to be outside of HUD as well. And it allows them to do master leasing, which I think is important because I have 3 clients right now with vouchers, 2 who are very, very ill who cannot find an apartment. And the wonderful thing about master leasing is that the contract is between a company called Brilliant Corners and the landlord, as opposed to a tenant and the landlord, where the landlord is discriminating against somebody who's homeless or they have a bad credit rating or whatever. So are you exploring that for the city and looking at a flexible subsidized housing pool as opposed to just always going to HACLA or looking at vouchers?
Or looking at the county, because the county is funding this program heavily in the city. So the reason that we're not able to do that is because, as you said, the flexible housing pool, what makes it incredible is that it's not federal money, and it's flexible in the sense that the units don't have to meet the same standards as they have to do with a HACLA voucher because of the federal regulations, but it basically works the same way as a project-based voucher in that you have to be able to make that rental commitment for at least 15 years. And really, from the tenant side, you want to make the commitment for as long as that tenant needs that rental assistance. So if it's 20, 30 years, you have to be able to make that. As you know, the city could not make that commitment because if the city were, if we were to buy into the pool, we'd have to be able to commit general fund dollars for at least 15 years. And the city just doesn't have the resources. And so that's why we're very happy that we're able to work with the county on the flexible housing program. And one of the things we're exploring with them, because part of the issue is master leasing is great, but you have to find the vacant units to be able to master lease. So we're actually working on an effort now with a few property owners that may be willing to convert their properties into residential, and we've talked to the county about using the flexible housing program as a master lease. But again, the challenge with the city buying into it is being able to commit general fund dollars for at least 15 years or more annually, right? Because once you support a rental subsidy, you have to be able to do it for years and years and years, unless that tenant, or else that tenant will be evicted.
Right. And then on the flip side, I would say that you're saving money, right? So the state of Utah has reached a functional zero in chronic homelessness, but they saved $8,000 to $10,000 per person that they housed into permanent supportive housing. So I understand there's a cost associated with it, but there's also a tremendous savings.
Oh no, and you should know the city already, and I think a lot of people don't know, the city already finances about 300 units of supportive housing a year. So when you look in terms of what other cities are doing, even the county, in terms of producing new units, the city, on average, finances 800 units of affordable housing a year through the Affordable Housing Trust Fund, and 300 of those are supportive housing, partnering again with HACLA, who provides the voucher for those tenants, and the city providing the capital for the project, the gap financing, right? And then being able to leverage that, of course, with the federal tax credits and other state and federal resources. But the city's already financing units. The challenge with the flexible housing program, again, is being able to commit that money for 15 years, committing it today for 15 years, and being it general fund money. I mean, if we had the resources, the city would, but that's the reason that the city approve the ballot or the measure on the ballot, because we don't have enough money to finance affordable housing units. Even with 800 units, it's not enough, right? And we're just not talking about the challenge with meeting the needs of our homeless population, but it's just the tremendous affordability gap across all income levels.
Then one other thing that I see in the community, particularly with my clients, is that there are developers who get money from the city to create affordable housing units. Unfortunately, in their application process, they actually exclude people who are homeless. So they require 3 years of positive rental history. And I've actually brought this to the attention of several council members and actually brought them the applications that some of my clients have been able to get. So in the development end of this, will you require that landlords accept people who are currently homeless?
Yeah, so in terms of the bond program, one of the things that we're going to really be sure that as the program is being developed is included is how homeless individuals, homeless and chronically homeless individuals will be selected for these units. And HUD actually, I think 2 months ago, issued a notice to ensure that as jurisdictions are financing units using some federal funds, and even if we use bond money, some of these projects will have federal funds because you want to be able to blend the units, right, with supportive units and affordable, to be able to ensure that the jurisdiction is using the coordinated entry system, right, which ranks folks in terms of need so that those folks are housed. And that's really a priority for the city, the council, the mayor. And in the bond language, you'll see that 80% of the bond proceeds have to go to the chronically homeless and the homeless individuals, and only 20% of the proceeds can be used for other affordable housing.
Great. Then I just have one more question. Sure. Government oversight over the private nonprofits that are sort of providing the delivery of services and how that, basically how it can be strengthened. So I have a number of people couldn't get into shelters, couldn't get services, for whatever reason, mainly the programs were full. My understanding was that they were supposed to be entered into the coordinated entry system so that we have an inventory of people who are in the area whose name could ostensibly come up because they have a high SPDAT score or whatever it is. But that's not happening. So, and there doesn't seem to be any place where they can go. There's no government oversight. There doesn't seem to be a place where you can go to complain about that or to make sure that these private nonprofits are actually entering people into the coordinated entry system. It's very concerning to me because for the majority of my clients, I have to go and double back with these nonprofits. A lot of them, have shelters associated with their programs, and force them to put people into the coordinated entry system because they're just saying we're full and goodbye, and they're not being entered. So there's not really a good inventory. So I'm really concerned about that, and these are people who tend to be living in their cars for the most part now because they can't get into a program. And it's very concerning to me that they're just out there and they're not actually in the system.
Yeah, so, I have to agree with you. The coordinated entry system is proving to be one of our major challenges. And so both the city and the county are making major investments in the system. Part of the challenge is the infrastructure that LASA was using really couldn't support the type of system that we need. And so they just actually hired a new contractor to be able to improve the system and data. But I agree with you. It's one of the major challenges, and it's something that we're looking at very closely, again, with the county, because the coordinated entry system, is managed overall by LASA. But, of course, it will support all of our programs, both city and county, and so it's a critical importance. So I agree with you. It's one of the biggest challenges that we have to address, and we're working on that.
Great. Commissioner Sharp?
Other set of questions.
Oh.
In addition to supplying housing, what are ways that the health needs of the homeless population can be strengthened?
So, again, we're working very closely with the county to ensure that we're coordinating the services for these units, right? Whether it's health services, mental health services, and then, of course, other resources such as job training. As part of we're expanding the case work and emergency response teams to ensure that, one, folks are being entered into the coordinated entry system, but also that they're being connected to those type of services that they need. And of course, health being a major priority for most of the clients that they're seeing.
Yeah, I guess as we've heard that the demand for housing is not matched by an adequate supply, hence the $1.4 billion bond proposal. I guess I'm asking, is there parallel on the health side? Is there a series of needs that are not being met from a supply side of trying to meet a homeless person's health needs specifically?
So I actually think that on the health side, I mean, there are always challenges, but again, have been really impressed with our county partners, because as you know, that's the city unfortunately doesn't have a health agency, and again, most of the services or support that we provide through LASA is to be able to connect with the county services and other supportive services. But I think that the biggest challenge, because as you know, for someone to help you stabilize and receive sometimes the health service that you need, is we need to get you somewhere, right? And it's very hard to have people on the street to get the services that they need. I think our biggest challenge in terms of helping people stabilize, because of course that's why we need permanent units, right? The first step is helping you stabilize so then you could receive the service that you need, is we don't have enough funding for the type of transitional housing that we need and temporary housing. That would then allow folks to be stabilized to get services and counseling that they need. So that's one of the major challenges I think that we have in terms of the city. And part of it is, again, just the lack of resources. We were able to fund 24-hour shelters, which will help. And that's part of the plan and the funding for this year, so that will definitely help, but definitely won't be enough for what we need this time.
Any other questions?
Question, Commissioner Hawkins. Thank you so much, Yolanda, for being here. I'm so excited that you're leading this effort. I had the really wonderful opportunity to work with Yolanda in D.C., and just so very impressed by you and so very excited that you're helping the charge on this issue.
Thank you.
So one thing that you mentioned is you're noticing that you're seeing the county put up its proposal, the city putting its proposal, the state putting up its proposal. So interagency, you're starting to see that taking shape, and you're also starting to see, like you discussed, the interagency discussion. However, we're starting to notice, like as an FQ, that the businesses and other folks who are directly impacted aren't at the table as well. We kind of feel like the government entities are working in silos. And so we're trying to figure out what's the best way for us to be a part of the solution, especially right now as an FQ, dealing with the issue of homelessness and recoup beds. So understanding when we do see the homeless population and we do service them, however, there's no follow through, there's no casework management, there's a transient population. So it's now directly impacting as the Health Commission. We're starting to notice things like the fire department now having to take on this issue, or different other entities having to put their primary services aside so they can address the acute issues of homelessness. So how can we, one, work together as the Health Commission, but two, bring the other public-private partnerships and businesses and other health entities to the table so we can work together to come up with a solution?
So thank you for that question, because I think that it's a great opportunity for you to especially bring private health organizations or nonprofit private health organizations that may be willing to support this effort, whether it's through supporting some of the sobering centers, providing additional services. I mean, we're getting great support from a lot of the business sector downtown. The LA Chamber of Commerce is very involved in the Funders Collaborative, the United Way, the Central City Association, but we really have not seen a lot of the health providers be as involved. And so I think it would be a great time to bring them together to talk about what the city and the county are doing. And see how how you all can be a part of that, because in terms of the the resources that are needed to solve this problem. I mean, 1.2 billion sounds like a lot of money, but we may be able to finance 8,000 to 10,000 units. And that's a start, but that's about supportive housing, but there's also this other issue of how do we provide all the services that are needed, and maybe some of the health providers are willing to fund some of the temporary shelters where folks can get health services, and some of the temporary housing that we need. So we would welcome you bringing those stakeholders together, because again, I'm not sure if the county has seen that since they work directly with many of the health providers, but at least on the city side, we have not seen health providers really step up on this issue.
Thank you.
Okay, any other questions? Okay, good. Oh, actually, I have one quick question. One of the things that we're looking at actually is the lack of sort of drinking water and potable water and bathrooms.
Yes.
That are accessible for
Yes.
people who are homeless, and particularly on the street. So what are you looking at in terms of increasing that?
Yeah, so one of the strategies, it's a priority and that we're working on now, well, there's a couple. One, of course, are storage facilities, but the other are mobile bathrooms and showers. And so I think you'll see shortly a proposal from the city as to how we're going to do this. The other program that you'll see coming for shortly is a safe parking program, understanding that so many folks are living in their cars and they need a safe place to park where there are some mobile showers and bathrooms. And so we're working on all three efforts. So I think the first report that will be released to the Homelessness and Poverty Committee is the Safe Parking Program, and that should happen at the end of September.
Great. Okay, any other questions? Thank you so much for coming.
Thank you. Thank you.
Okay, now we will move on to public comment. Mr. Spindler?
Yeah, the pig will address.
So that's how we get only one fucking minute for 3 reports? Is that correct? We're going to get 3 different reports that are not generic to each other, aggregate them in one item, and only give the public a lousy fucking minute to talk about those 3 reports. Boo-hoo! Another violation of the Brown Act, because the Brown Act requires public comment on each report separately because they are not related to one another. They are completely different. And you know that. That's why we bring puppets like me to these puppet meetings. Because the city's ran by puppets. For puppets, by puppets, of puppets. Homeowners don't mean shit. Take 8th Street in South Coronado. Why are all those goddamn homeless and drug sellers selling drugs and living in those goddamn shanties for 14 straight months? How come we, the people, have called 94 times to the city and you still don't remove the instruction? Because they're fucking shipping the homeless west from downtown development over to Koreatown, Lafayette Park, and all the other places west of fucking Vermont. That's why they're doing this. That's why they want more money for housing. So that's why the pig says, vote no and HHH and RRR. No more taxes. Let's sue the city and get these fucking things taken care of on 8th Street in Coronado.
Okay, item Number 2 is a report back from working groups on homelessness and lifestyles, and discussion and possible action on consolidation of working groups and/or elimination of low membership working groups. Commissioner Sharp, do you want to start with the lifestyles report back?
The first and most exciting piece of business to report from the Lifestyles Working Group is that it's now called Healthy Living. Second, there have been a few phone calls, and we have identified a universe to try and focus on, which is the sort of policies, programs, and commitments that the city and county have made to make it easier for people to live healthy. And that's everything from tobacco prevention to parks and open space, which we've heard a little bit about, to healthy eating, and are hoping to incorporate in this, because I'm not sure that it fits elsewhere, the transmission of both STDs and infectious diseases as a subject area that's come up multiple times. So within that universe, there has been some support from the CSUN team to try and just simply put together the relevant recent city and county commitments in these areas, so we can see where there are already goals articulated, many of which have been done within the last 18 months, and therefore to at least this particular working group appear effective, relevant, and still of value for policymakers and the public. The challenges are twofold, or maybe multiple-fold, but I'll only do two in the interest of time and interest of sparing you all. The first set of challenges is around having some consistent metrics or benchmarks against which to measure progress, or toward which to measure progress on achieving these goals and objectives. There's a great lag between the underlying population data that's collected by the various sources that try and measure what's the rate of smoking, what's the rate of cardiovascular disease, et cetera, and the actual commitments and the plans to change the environment in ways to make it easier for people to live healthy. And so our ability to pin down exactly how the world looks in 2016 relative to the various plans, commitments, and objectives is a little difficult. The second challenge to which I solicit your support and assistance is to help identify a number of editorial choices that we're facing, or to identify some responses to some of the editorial choices we're facing. For example, there are a lot of areas where the state government plays a jurisdictional role, whether that's the environmental toxins that surround us in the air, or the Exide lead smelter facility. There's a number of things we've heard about here previously in terms of hydrocarbons that have some example of impact from an air quality standpoint. There's monitoring being done and or regulatory authority within several state departments. How much of that do we actually want to get into in the work of this commission, given that our jurisdiction is the city and some of our focus is the county? And then the second set of editorial choices, which I think are even more complex, that I'd appreciate your solicitation, I solicit your support on, is to determine what to do with competing assessments. I don't think as a commission that we've collectively identified a rubric through which we consider whether the testimony of any member of the public or of a medical professional or of a community organization is balanced against other sorts of facts and potential considerations. So those are two among multiple challenges that I think we would benefit from your help on, to try and sift through what's an enormous diversity of information in order to try and focus on a handful of actionable and relevant population-level recommendations for all 4 million Los Angeles residents.
Great, thank you. If that's okay with the two commissioners here who are on the homelessness work group, I'll just give sort of a brief overview of what we've covered. So the commission actually is on record for supporting the county's Housing for Health program. This provides for people who are chronically homeless who have visited a county health clinic or hospital twice in 1 year, who also has an underlying medical condition, access to housing. And they connect people to vouchers, but they also do the master lease program. It's been fairly successful, and doesn't have quite as many hoops to jump through as some of the HUD programs do. So we're actually on record for that. So that will be one of the recommendations coming out of our work group. We've talked about supporting and expanding sobering centers. You heard about the fire department and a lot of the work that they do, basically servicing people who are homeless, particularly on Skid Row. There are a lot of, it's really pretty much an ongoing thing on Skid Row that the fire department has called out for people who are inebriated or anything that's sort of happened to them. Whereas if they were able to go to a sobering center, they could be linked to services and given time to sober up. And it's just less taxing on the fire department, and also just better for people who are living homeless on Skid Row. We talked about veterans homelessness and looking at a lot of the barriers that are faced by that particular population. That's endemic to that particular population. Looking at health access barriers, so from transportation to not having enough storage to leave their things so that they can go on appointments. Looking at those things, looking at the lack of water and bathrooms that are available, looking at communicable diseases on the streets, and then looking at some of the discriminatory practices and the lack of housing specifically for people who are homeless. So I think that's sort of a brief overview. Our group at Cal State Northridge has been doing a lot of research. I think we're ready to start the writing phase at this point. There's a little bit of information that they're still looking for that we've asked for research on, but for the most part, they've done a pretty good job getting the information together. And we have people, commissioners who are in our work group who also work on homeless issues. So that's been helpful as well. So that's sort of where we're at. Okay, great. Okay, so I'd like to move on, actually.
Can I get any feedback on the two questions I asked earlier, or confirm that there is no feedback? My two questions were, one, do folks have a preference regarding whether matters that affect the health in the jurisdiction of this subject area that involve state and federal governments that are outside the original scope of this, do we leave that alone? Do we focus primarily on the city and county governments as sort of an editorial choice about where to focus? And then the second area being, what do we do with subject matter that's not come in front of us, where we haven't had a specific expert? How do we endorse or sift through what is, potential universe of, hundreds, thousands of potential sources of expert reports and so on? Does anybody have any guidance on that? Commissioner Andres Taylor and Commissioner Cotto spent a fair bit of time with us on a couple calls going through this, and we thought it would be good to get anyone else's reactions while we were together in a full group, if possible.
Commissioner Mandel.
I think this healthcare is so financed by federal and state government that at times you have to consider that information or data, because we're beholden on federal law, as well as the financing of most of these programs is going to be attached to federal money. So I think we have to at times do it, though I don't think we should, overreach what we're supposed to be doing, and we're not the U.S. Congress. In regards to the second, point, is it's our responsibility as a whole to get data that is accurate and valid, and if there is an issue that's going to come to a vote, then we have to find the appropriate scientific data to support whatever issues might be. And there's always two sides to everything, and there has to be some debate on things. So I think that whatever it might be, let's say, for example, viruses affecting LA City, you need to have a virologist or a public health person, or you need to have a scientist who understands viruses to discuss it. And if we have a presentation from somebody who's not a specialist in that field, it doesn't really help us. And so we need to seek out and bring in the leading experts that we can. That's our responsibility. That's a fiduciary responsibility to the people of the city of Los Angeles.
I would say, in the interest of time and expertise of the group, I would defer to the leadership of the group and the group itself. Full faith in whatever you decide. Thank you.
Okay, so you should have before you the list of work groups and the membership within each work group. Now, there's a few that I think we can consolidate. So one of the things that we talked about in our homelessness work group was consolidating veterans into homelessness and working just based on veteran homelessness issues or a number of other issues dealing with veterans. But we thought sort of in the interest of time, and since the membership is, with the exception of one person, it's pretty much the same, basically combining those two. The other thing I'd say, there's only one commissioner in education employment, and I'm not exactly sure
Yeah, I'm not even sure what that's about
what
either.
that's
so feel
about.
free
I
to-
know it
feel
was one
free
of
to
the things
strike
you
it.
put through.
Strike
Okay,
it.
great.
Thank you.
So if everyone is okay, I'd like to strike that one. Under environmental, Commissioner Vick and myself are on that particular committee, although I'm wondering if, since we have a subcommittee now on oil and gas, if that's fine and we could maybe take this out?
Sure.
Do you think so? Okay.
I agree.
Okay. And then that would leave us with homelessness, veterans, health equity, healthy living, and medical care services. Or no, yeah, so it would leave us with 4. So it would leave us with homelessness, health equity, healthy living, and medical care services. So that would be the 4 working groups that we would work on to create the annual report. So is there any discussion on that? Are people fine with that?
If I may, I'm just trying to understand how we're going to accomplish this. Now, my understanding is, I guess, when you all had one meeting, it was done by phone, is that right?
Yeah.
And did
by
Candy
conference call.
coordinate that, or no?
No, the work
so-
groups, yeah, the work groups just organized. The work groups are basically to help inform the researchers on what we think the priorities are, and just help to sort of guide them.
Did they participate in the
And they
discussion? I
participated,
see.
yes. So that's why we were waiting to convene the work groups, to get the research body group on board so that they could be taking notes and understanding where we were going, since they're technically writing the report.
Do we know that, in fact, that there's somebody, for example, prepared to meet to talk about the medical care section? I'm just, because that's when I'm on. I mean, we would coordinate with this person and discuss.
Yes, so we're
the
hoping
issues?
to convene that in the next week or so.
Okay.
And then at the time that you have that call, there would be researchers who are actually on the call, and they'll be documenting. So they'll be creating minutes, but they'll also be documenting what needs to be researched in terms of the highlighted areas. So I think it's worked out fairly well on homelessness. I wasn't on the healthy living call, but I think that it's moving along, I hope. And then we can convene the other 2 groups, and then we're really just providing guidance.
Okay.
One question. The health equity frame and lens is the sort of overarching theme of the city's plan for healthy Los Angeles, and it's a thread throughout every meeting and every subject matter we've discussed here to date. There have been several of the subject areas that are identified under the healthy living heading that in practice the recommendation is to achieve health equity, A, B, or C would be changed. So I'd love to know what is conceived, and it's actually a couple of the same folks. What are examples of some like subject matter that might be addressed separately under the health equity group, distinct from how health equity is sort of like a lens through which we're trying to see some of the other problems and solutions?
I wish Sal Esparza was here because I remember that he spoke to this when we created this particular work group. And there are some notes to that, but I don't actually have them on me. So I think we can send that out, but there were specific things. Is when we created the work groups, we documented what specific sort of subgroups or issues that we wanted under each one of these. So there is information on that. I just don't have it. Okay, so are people fine consolidating it? Consolidating these groups? So we have 4. Okay, great. I don't think,
That'll make
Commissioner Cato?
it three groups, right? Or,
We have 4 groups, actually. There's homelessness, health equity, healthy living, and medical care services
okay.
right now.
Was your suggestion to consolidate health equities?
That is my suggestion, but there may be information missing that I'm open to.
Yeah, so we don't, yeah, I mean, I think if we decide that it's unnecessary, we can just not meet with that group and not provide guidance for that for the annual report. Because these are not subcommittees, just to be clear, these are just working groups. So we can decide to convene or not convene any of these work groups for the purposes of the report.
So this may not be
But
why Commissioner Esparza has experienced some personal challenges and has been unable to be part of the groups or the conversations to date. I've been corresponding with him a little bit electronically, and I'm happy to just simply ask him again what were some of the specific subject areas, just to make sure that there aren't any lost threads that we're not addressing in the other groups. It's certainly important to capture all the areas that are of passion to the commissioners. I'm optimistic that the way it's that much of the subject matter is covered in one of the other areas, but I can specifically ask him about it.
Great, okay. And these were not voted on as specific work groups, so we're fine just consolidating them without a vote, is my understanding. Okay. Item 3, discussion possible action to recommend continuation of contract with the county for health department services. Commissioner Sharp? Oh, I'm sorry. I'm sorry. We do need to move to public comment. Wayne Spindler?
The pig will address.
What you could do? No, you don't need all of these committees and subcommittees. You need a committee on 8th and Coronado Street. 8th and Coronado Street to get rid of the terrorism that I've suffered for a year and a half with your homeless clients living in shanties. Where's the committee on that? They live in shanties in the middle of a vacant lot that your city council approved for an 18-unit condominium project that was never funded fully. Back in 2008, I said no, but your city councilman then, Mr. Reyes, was paid off and he said yes, and the project went belly up and there's a vacant lot there. And all of these people are building these shanties. They look like fucking shanties. And they're using them for bathrooms, they're using them for everything. Then they moved down the street to James M. Woods to colonize more territory. And then some of us have to push the garbage out. So that's what we need a working group on. Working groups with puppets. Puppets like this puppet here. Because what we're trying to do is demonstrate to you all that this city is ran by puppets. We pay the taxes. We pay the property taxes. We clean the fucking streets around our properties. And for what? So you people can let these people live on the streets and destroy our way of life. I don't think that's equanimable, do you? So I say, go to 8th and Coronado tonight and begin the journey down the road.
Okay, thank you. Okay, item number 3, discussion possible action to recommend continuation of contract with the County of Health Department Services.
Thank you. I would like to make a motion that the Health Commission requests the City Council to consider and renew the contract with the county to provide health services. The background information you need to agree to either second and or endorse or vote against said motion is that in Section 3 of the underlying ordinance that enacts the Health Commission, we're required to evaluate on an annual basis whether the health needs of residents are best served by continuing to contract with the county to satisfy such health needs. With the assistance of Joshua Dabrowski from Public Health and a number of others, we've gotten a hold of both the Public Health Code to which this refers, as well as the city's 1964 agreement with the county establishing said relationship. With the help of Ms. Candy Rosales and Brian Walters from the City Clerk's Office, we conducted a brief survey of City Department General Managers to determine their level of satisfaction with said relationship and with the county's enforcement of the health code, and I'd like to, on the basis of the information we've received, the discussions we've had, any ex parte communications I've had with stakeholders that have provided input about this, I've come to the judgment that the City of Los Angeles should continue contracting with the County of Los Angeles to enact enforcement and implementation of the health code. Do I have a second?
I'll second it.
Okay, as rudimentary as the contract is. Fine.
Okay, it's been moved and seconded. And the motion is to recommend continuation of the contract with the county for health department services. All in favor, please say aye.
Aye.
All opposed? Any abstentions? Okay, great, that passes. Okay, our next item is item number 4. Oh, I'm sorry, public comment. Wayne Spindler.
The pig has wrote notes.
Discussion and possible action for the contract with the county. You don't want the county. The county is run by Hilda Solis, and Hilda Solis has a big problem. Hilda Solis has silenced public comment at county board meetings. She's operating in secret. What is Hilda Solis hiding from all of us? 96 items on last Tuesday's agenda, and only 6 minutes of total public comment? Hilda Solis is hiding something. And what is Hilda hiding? The money. What else? And you want to contract with the county right now? In the face of the Hilda Solis regime? I don't think so. Sounds like a bad deal. But to violate the Brown Act, you already voted to approve the item before public comment was closed. So see, you also violate the Brown Act like she does. And what about Mark Ridley Thomas on the County Board of Supervisors? Herb Wesson wants his seat. And we know what happens when you get in the way of Herb Wesson Jr., don't you? Actually, his name is Herman Wesson. Yes, you know what happens. Mark Ridley Thomas is in danger. Hilda Solis is hiding things. And then Mike Antonovich is leaving. So the city is dealing with a chaotic board of supervisors with corruption. Please reconsider your vote and vote hell no on this item.
Okay, thank you. Item number 4 is an update on research for the council request regarding mapping of wells and pipelines. So in April, there was a motion put forward by Council President Herb Wesson and Council Member David Rue, and this was to look at our wells and pipelines. A lot of it is just sort of technical information and just an inventory that is available through Dogger. So I just wanted to give an update on sort of where we are. So we do have an inventory now of all of the wells in the city of Los Angeles and the county, their age and history, casings, and right now I'm looking into leaks coming from those wells. They've also looked at abandoned wells, and obviously that's been in the news recently, particularly with the Echo Park situation, and that's all a matter of public record, and so we would just be sort of consolidating that information for the city so that they can make recommendations.
This is not an action item for us, is it?
It's not, it's just an update. So, okay, so are there any questions?
What should any of us know or do? It sounds like you've put a lot of effort into learning about or engaging those who know a lot about this. What's the role of the rest of us in helping get this to the finish line to respond to the request?
So based on this motion, we created a subcommittee that primarily was on oil and gas, and Commissioner Vick and I both serve on that commission because we're that subcommittee because we were the only ones who signed up for it. So if anyone else is interested in this particular issue or has expertise or would like to connect us with other folks, that would be great. There are a number of particularly state senators who have offered help to connect us to the information that we're looking for, 'cause some of it is handled by the state, and they've already been working on a lot of these issues, and we've obviously had people come and testify already on this particular issue, particularly from the county last month, talking about where they were in terms of looking at the inventory and the leaks and things like that. So there's a lot of information that's already been compiled, and Dogger has a lot of this information already that we just, are getting from them. But we do at least have an inventory of the wells and the history, which is, I think, in itself a good move forward.
Question. Was this motion passed by the city on April 15th? I'm looking at what I see here.
Yeah, I think so. So it was passed and then moved and then signed by, I guess, 7 of the council members.
Right.
In terms of it being seconded.
Well, so it's 180 days for a report.
Right, so that would be December. It's a recommendation. So the
180 days.
September. It's getting close. April, May, June.
Oh, it's November.
15th. The last time I'm checking my math. Which
Yeah, but
means today is now September 12th, which means we have 4 weeks to make a report without a presentation, without data from all these agencies that are supposedly giving us assistance.
This is a recommendation by the council in terms of the number of
it's not a
days.
recommendation, it's a
So,
request.
yeah, it's a request.
So
Right,
I think
it's
that
a request.
We should respond to the city council that there is no way we're ever going to have a report by October 15th because we have not had a presentation from the people that are supposedly assisting us, CAO, CLA, BOE, Fire Department, or DOT regarding these issues. So I think that, and I don't know legality, can I make a motion to do that, or do we have to give the public a month's notice before I make a motion? But I think the motion I would make is that we notify the city council or request the city council an extension of the 180 days because we haven't been given the presentations that we would need to make an appropriate report.
The 180 days, though, is not binding. So if it were, this is a request, if it were something more than a request, then we can give an update to the council in terms of where we are, and I'm in contact with some of the council members, but it's not binding that it has to be 180 days. We didn't even know about this actually until a couple months after it passed. So,
That surprised me, but so whether we formally need to make a motion or not is irrelevant, then I would say that we should, out of respect to the city council, notify them that it's not happening by 180 days, and that we will attempt due diligence to meet or have presentations from, or get a report from each of these groups.
Yes.
So we could at least make an intelligent statement upon what they asked us to do.
Great. Yeah, and I think some of these departments actually are not actually working on oil and gas issues, so that's been a little bit of a problem. Particularly the fire department doesn't keep records at the county level or at the city level, but they may at the state. So we're looking into that right now.
I mean, the
We
fire
did a
department.
presentation once, and there was discussion of the fire department looking into.
And that was
well,
for state. Yeah, that was for state. That was a presentation from a community organization that had pulled information from the state, from the
Not LA
state
City.
fire, but not LA City, no.
fire department.
So that's, yeah, so that's been a little, I've been back and forth with the city of LA Fire Department, and they
Has there
just
any
don't keep
work
records.
actually transpired toward doing this?
Yes, so we have an inventory of all of the wells and their
Now, who
history
did
and
that?
age.
Who did the inventory?
Well, we got that from Dogger. I asked for that from Dogger.
I'm not sure I know who Dog.
Dogger is with the state agency that keeps all of these records. So they have an inventory and a mapping of all of the wells, and they they keep an inventory of which wells have a history of leaks and when those are. And it's just a matter of digging the information out and asking them for it and reaching the right people.
How much more information do you need to get?
Well, the information on the leaks is sort of the next step that we're at to look at which wells have been leaking or have a history of leaks and what that is and if they've been capped. There's a huge issue right now with abandoned wells, and these are wells that have literally just been abandoned by whatever company had owned them or entity had owned them. And so no one is, no one is monitoring them, no one is capping them. And so the state is looking for these wells and looking to cap
But
them
the
and has
list
put
that
money
you've
toward
got
it.
Would have them somewhere on the list and say.
They would be on the list,
there
and then
was
I have
something there
to.
in 1938, and we don't know where it is now or something?
Well, no, the abandoned wells would be on the map.
Okay.
It's just that they wouldn't be listed necessarily as abandoned. And so there's about 800, I think they said, in the city of Los Angeles. One of them obviously was leaking within the last few months. There was an LA Times article about it in someone's front yard. And so they were able to go in and cap it. And there's money that Dogger put specifically toward looking for these capped wells or looking for these abandoned wells to cap them. And so the city is asking us if we could, get that information from Dogger and have that as part of our report so that we know exactly where those wells are. And now that we have the mapping and the latitude and longitude and the API numbers for each of those wells, it'll be much easier to just plug
Now,
those in.
Who physically is going out and doing that?
Well, the
Who is
information
it?
comes from Dogger, so it's really a matter of a phone call.
I see.
Yeah,
So
because they have
Dogger
the
says
information.
there's a well at such and such a location. Does
Yeah,
somebody go and look at it or do anything about it? I mean,
You mean, does the state or the city do
or
that?
the city, yeah. Is
I think
anybody-
the city is looking into doing that since we've just found that.
Thus
But
far,
I
we
think they're
don't
waiting to
figure out who that
for the
might be.
report to come back so that they know exactly where those are. And that report
You
doesn't.
guys aren't going and looking at them.
No, I do not. There may be a few wells that I'll look at, but but that's just because of interest.
Well, yeah, I mean, the fire department's so pushed on their inspections that it's probably hard for them to allocate personnel to do it, because you've seen all the problems, including the departure of the.
Marshall.
Yeah, the fire marshal, a friend of mine. So they're kind of behind the curve, too, on a lot of inspections, so I don't know who else would do it. Building and safety, I don't, anyway.
Yeah, the question is whether or not they keep records. So while they may be involved in some of these processes, and I'm sure they're involved if there's a leaking well and
Yeah, if there's a
someone is impacted, but for the most part, they do not keep records. So there's not a place where you can go to see those records for county or city.
Are we losing quorum?
Okay.
Are we losing quorum?
We're losing quorum.
Yeah.
No, just to start,
I'm sorry?
just to start.
Just to start.
No, if someone,
I said, are we losing a quorum right now with Vic leaving?
okay, so are you calling quorum?
Yeah, I'm just asking, yes.
If you're calling quorum, then we
Calling or
can stop the
asking?
meeting.
We're losing if she's leaving.
She's leaving, we're losing
We're losing a
quorum.
quorum if she leaves.
Okay, we lose quorum if she leaves. So we're,
She's leaving, so we are losing a quorum.
I think she's asking the question.
No.
She's not.
okay,
No,
well,
I'm not calling, I'm asking just because I physically saw a commissioner leave, so
Yes.
I'm just
okay, but,
finding out the status.
One of which is we can make a complaint about it, in which case we stop. The other alternative is we can go on with the meeting. Is that not correct?
No, we can't go on.
once it's mentioned that quorum is lost,
8
we have
members
to
is a
adjourn the
quorum.
meeting.
Sorry,
You had a comment, though, regarding the subject matter?
I did. Can I comment, or it's done, right?
She's gone. No, sorry.
Okay, I'm sorry, we have to adjourn the meeting because a quorum was called, so we will hopefully agendize these for the next meeting. Thank you.
Let's go look for wells.
Sorry, I was just physically, it was a legitimate question.
quorum, the meeting's over.
No, I was just, no, I was,